So I've now got the pleasure to introduce our next speaker, Dr. Peter Hall, who is a consultant medical oncologist and honorary senior lecturer at St Bartholomew's Hospital, Queen Mary, University of London, specialising in breast cancer. So his current role focuses on the management of breast cancer in cancer clinical trials. He has a research interested in breast cancer translational research and clinical trials, and is the chief and principal investigator on a number of early and metastatic breast cancer trials. We introduce Dr. Peter Hall.
Hi, Mr. Doing.
A good comment, I think, to start the talk off. Thank you, everyone. Thanks very much for everyone coming in person and to all of those online today. I'm going to give you an update about where we're at with breast cancer trials and treatments and where we might go in the future a little bit. And this very much builds on the work of, builds on the story that Thomas put forward from the bladder and renal side. So, first of all, breast cancers are not all the same. Okay, on the one level, they might look macroscopically when you take them out and have a look at them. But actually, when you start looking at the details under the microscope and do particular stains on them, Tom's mentioned about the HER2 protein, for example, you can start identifying there are different subtypes, different ways of classifying them. So there's one type which is very much the commonest type, and that's driven by hormones, estrogen, as you might have heard about. And that takes about 70% of the types of breast cancer. There are some cancers which are not driven by estrogen, and then there's some which are driven by the HER2 protein as well. So this is where the Herceptin antibody comes in that we've heard about already. And this is important because it not only affects the outcome, so the estrogen-driven ones tend to be less aggressive, for example, the hormone-independent ones tend to be more aggressive, but also affects the different types of treatments that we give. So obviously, if it's driven by estrogens, a lot of the treatment is directed towards blocking estrogen, and we can talk a bit about what that means. HER2, for example, as I said, we give HER2-based therapy, and there's a range of different drugs based still around the Herceptin antibody, but again, now moving into antibody-drug conjugates. But the one that's been tricky is what we call the triple-negative breast cancer. So this is the hormone-independent, HER2-independent. And there's no obvious targeted therapy option for this. And so this is taking us back a little bit. This was about 5 years or so ago. And the mainstay of treatment for this was chemotherapy. And this is both in the early breast cancer setting where you're trying to cure them, patients, but also in the metastatic setting as well. And one thing I'd like to just take away from this slide, we're going to come back to this a bit later on, but it's actually the limited number of options here and that. So of these, the light grey boxes are different chemotherapy options. You'll actually notice that one of the drugs is mentioned twice, actually. And so actually you've got very limited options in actually how you're going to treat these patients. And so in the metastatic setting for triple-negative breast cancer, the actual time of survival, sadly, was very short. So just over a year to just over a year. And you can see that actually, as you used up, the response to each treatment got shorter and shorter with time as well. So this started to change when actually looking at the biology of triple-negative breast cancer and moving the initial trials using immunotherapy. And so this again is actually a way of using the body's own immune system to attack the cancer. So we know that actually cancer cells actually have a camouflage to themselves so that actually the immune system can't see them and recognize them as foreign and kill them as the role of the immune system normally is. There's obviously is normally targeted against things like bacteria and other infectious agents, but also it works for cancer as well. But actually, as I said, the cancer, so this is not just breast cancer, but other cancers as well, hide away. And there's some seminal work done in the 1990s and early 2000s, showing that actually if you give antibodies to block certain proteins in the immune system and also that are present on the surface of cancers, you can actually allow the immune cells of the body to go on and attack the cancer. And this was one of the first principles of this in breast cancer. And this is work of Peter Schmidt's, showing that if you give a drug that's an immunotherapy drug that allows the immune system to go on, you actually get an improved response. And what you're looking at here again, this is a measure of how likely it is, or how many patients have significant shrinkage of their cancer with this treatment. And what this is doing is, and this is not a small amount, again, you have to do it by over 30%, so you're having a good response to that treatment. And this is used as a surrogate to measure actually the likelihood of the cancer not getting worse on a particular treatment. And then also, hopefully, again, things actually people surviving longer as well with it. This has been used both as the first line treatment, so when patients first come for their first treatment with MSA, and you get a good response. But actually, the later lines, actually, the response is not so good. And there's work ongoing at the moment as to try and understand why that might be the case. So does this actually improve survival? The answer to that is yes. So this is in patients who come for their first treatment. And there's two significant trials here. These, again, are Kaplan-Meier plots we're hearing about, looking at the chances of actually dying and whether that's altered by these treatments. So the standard of care at the time was just to give chemotherapy. And you can see that's the line that runs at the bottom of both of these graphs. These represent two different trials. And so this is the line with just chemotherapy. And this top line then is looking actually at giving chemotherapy alongside immunotherapy drugs. There's two different ones that we use. One is atezolizumab and one is pembrolizumab. But they have the same principle of what they're doing in allowing the immune system to go in and attack the cancer. And in both cases, there is a significant overall survival benefit by giving the immunotherapy alongside the chemotherapy. And this work now has improved survival to over 2 years. So it's up to about the 2-year mark on average with these. Again, so from where we were before with about the 12, 15-month mark, we're now pushing it up to 2 years on average. And obviously some patients do better than that as well. This has now become the standard of care globally across around the world. One thing that's interesting now, one element of that we're going to come back to talk about at the moment is, again, as we've been hearing about, not all patients benefit from these new treatments. And so what we have to do is try and understand who are the ones who are likely to benefit from it. And obviously that will help them. But what we don't want to do is give drugs that are not going to be effective for patients, because obviously that leads to toxicity and side effects without the actual benefit coming from it. And we've got some rudimentary tests for this, and we need to work better at this. But one of the ones that's very important for this currently is what's called the PD-L1 status. And this is the particular protein expressed by the cancer that causes the camouflage. So if you have that camouflaging protein present, then you're more likely to respond to having it blocked, which kind of makes sense from that side. So at the moment, these are only suitable for patients who are PD-L1 positive. And there's work ongoing, as we're going to come back to in a minute, about what happens if you're PD-L1 negative in this. Antibody drug conjugates, again, come into breast cancer in quite a big way. I won't go through this in quite so much detail. Tom's has spoken about this. But this is just to add that this is, so when the antibody binds, this is what this little grey graph is showing. This is the surface of a cell. And this is supposed to represent a protein within the cancer cell. And this is the antibody with its payload coming to attach to it. And what happens is it gets dragged into the cell. Is one way in which this can work. And then when it's dragged into the cell, it actually gets broken down, and the chemotherapy bits, these red stars, which are the bit that actually kill the cell, then get released. And this is how the first generation of antibody drug conjugates mainly worked from that side of things. So actually the drug was taken into the cell and killed the cells, the cancer cells, that way. What's been found over time, though, and with the second generation, the third generations of antibody drug conjugates, is actually the release around the cancer cell is also a very important mechanism of actually killing other cancer cells and improving how well these drugs work. And sometimes this can come from the chemotherapy coming out of the cell, but also actually it can be the drug being directly released in the neighborhood to it. And this is what's called the bystander effect. And one thing that's really interesting with this is that actually the way in which this linker here, in which the chemotherapy is attached to the antibody, turns out to be a very key part of this process. And so over time, as linker technology and understanding has improved, then how well these drugs work has also improved. And so what this is, the significance for this for patients in particular is that when you started with the second generation of antibody drug conjugates. So the grey cells in this are the ones in which the antibody is targeting. You actually needed a lot of positive cells initially to get a response to the antibody drug conjugate. As the technology has improved with the different chemotherapy parts, but also the linker parts as well, actually what you can now do is you can have low levels of the protein expression and still get a very good response to the drug. So I'm not sure how many people have followed with the breast cancer side of things, but if in terms of breast cancer, so Kadcyla, TDM1, was the second generation drug. It worked only if you had what we call 3+, or the highest levels of HER2 protein with it. We've now moved on to using a drug called trastuzumab deruxtecan and HER2. Been a lot of press about this recently. And again, that initially was used only in high levels of drug, but actually over time, they found that actually you can come down with the amount of protein that's needed and still get a very good response. And actually the latest trial, which is just published, just had its press announcement, hasn't published yet, called Destiny Breast 06, has shown that you can have ultra low expression of the HER2 protein, so low, well below what we traditionally call positive, and still get a very good response to these drugs. So just to illustrate actually how much we've developed and broadened, it means that many more patients will now be able to benefit from these drugs. And move on from that side. And just again, this is just a quick example. So sacituzumab, Trodelvy again is one of the ones that have led the way with this in breast cancer. Again, it's improved survival, and this is significant. This is 6 to 7 month survival improvement in patients who have had 2 or 3 lines of treatment already. So traditionally very short survival times again. So we're now seeing clinically meaningful improvements actually in survival through these drugs. So the one on the other side here is Enhertu again, showing that you've got multiple more effective options coming through now based around this. Okay. I'm going to talk about this a bit quickly, then I'm going to skip on in the interest of time from this. Immunotherapy, so this was talking, the previous slides have been about the metastatic, where the cancer is spread to other parts of the body. In the early breast cancer setting, so this is where we're looking to cure the patients and to give them the best chance of the cancer not coming back again in the future. Immunotherapy has a significant role here as well. Now, again, what we traditionally do is give chemotherapy before the surgery, called neoadjuvant chemotherapy, and then look at surgery as a surrogate way of looking to see whether if all the cancer has disappeared. So when they do the surgery, they take the surgical sample to the lab, look under the microscope, see whether there's any cancer remaining or not. If there's no cancer remaining, that's called a pathological complete response, and it's been shown to predict the fact that, or to give a much better chance of the cancer not coming back in the future. And so what you find with, if you give immunotherapy alongside the chemotherapy, actually you get an improvement, a significant improvement in the rate of this pathological complete response rate of all the cancer disappearing away. And then this again has been shown to correlate with an improved chance of the cancer not coming back again in the future. So again, we're improving survival in these patients by around 40% of this. So very significant, clinically significant, important developments going forwards with this. Interesting, just as an aside, PD-L1, which was very significant in determining how well people responded in the metastatic setting, doesn't seem to be important in the early breast cancer setting. So there are quite significant differences in actually the immune responsiveness and the biology, which is still being looked into from that side. But it's interesting, again, you can't assume it's going to be the same between different settings of that. I'm just going to skip this. So where do we go with triple negative breast cancer from here? So one thing that's important is actually, if you get better at curing patients, what you tend to do is you build on what you know already. So already we've got more than 6 months of neoadjuvant, or around 6 months of neoadjuvant chemotherapy, immunotherapy, and then another 6 months after surgery. And again, for some patients, that's too much. Actually, again, you're going to get much more in the way of side effects than you will benefit from it. So there are what we call de-escalation strategies being looked into now, particularly around some of the chemotherapy drugs. So things like the anthracyclines, doxorubicin, long-term heart and other issues with them as well. Can we leave those out, but still have the same cure rate? And there's work going on around that with the antibody drug conjugates now coming in to look to see whether they can actually replace things. The other thing I'm just going to talk about quickly, and so also just before we do, so this is again going back to this graph that we had previously. So this shows just how things have developed. So this is again since in the past 5 years or so, where we had basically about 4 ish, are all chemotherapy-based drugs. And this is where we're at now with the treatment landscape for triple-negative breast cancer. You can see actually that there's immunotherapy has come in the first line here. We've got 2 different types of antibody drug conjugates. And I haven't spoke about this yet, but for patients who have particular changes, mutations within their genes, the BRCA mutations in particular, there's what's called PARP inhibitors that have come into this setting as well. Again. So actually the treatment landscape has changed quite significantly with improvements in survival as well as well-being for the patient, feeling better with this as well. So significant improvements from that side as well. This has also been in the case of the early breast cancer as well with improved cure rates. You can see again that the PARP inhibitors have come into this area as well. So where are we going next? Just going to very quickly touch on this. We've seen from Tom's work about the benefits of actually in combining the antibody drug conjugates with immunotherapy. So we're now back in the metastatic setting again from this side of things. The previously, again, this is looking at the response rate. So how much does cancer shrink with a particular treatment? And chemotherapy-wise alone, you've probably got it to about 30 or 40% of patients would have a significant shrinkage. Give the immunotherapy plus it as well, maybe 50, 60% of patients. Now we're looking again, this is a particular antibody drug conjugate called Dato-DXd with an immunotherapy drug called durvalumab. And actually now we're seeing that actually you can get response rates up to about 80% of patients having a significant shrinkage. This isn't little shrinkage, this is significant levels of shrinkage with it. Okay. And what's important with this as well, actually most of these patients turned out to be, in this particular trial, were PD-L1 negative. So the ones, again, that traditionally didn't respond to immunotherapy, by combining it with the antibody drug conjugate plus the immunotherapy, we are now actually being able to see a significant response in a group of patients who we didn't see this in before. Okay. So this is where things are going from the breast cancer side as well. So combinations based around this. Cancer vaccines, well, I haven't spoken about any slides on this, but again, we're just about to open a trial based around this. These are coming through on the breast cancer side as well, on that as well. We'll take it from there. So I'm aware time is running up. Maria holding up things at the back, so I'm going to stop there. Any questions?
We're actually going to do the questions as a panel.
Okay.
With Tom.
Excellent.
So I think I'm going to host the panel for questions. So if you both want to have a seat, because then the people online can see now. Can you see the questions online? If they're a bit in the chat. I will monitor them. I'm going to just sit. And then anyone got any questions for?
Yeah. I wanted to know, you mentioned NICE and FDA, and you said there's a difference in what they want.
Yes.
What is the difference?
I think there's a philosophical difference. Is the Americans look at drug development and drug discovery as a new opportunity, and they want to put new drugs in the hands of doctors, and let doctors decide about what's best for their patients. Whereas NICE looks at it in the completely opposite way, whereas they want to control which drugs are available for patients and give doctors very few choices about what's available for them. NICE brings cost into the heart of the discussion. The Americans are not that interested in cost. The Americans look at it, in my opinion, in a way that if we invest in drug discovery in cancer, yes, the drugs are expensive, but in the fullness of time, they become cheaper, but that investment means we can change outcome. And Europe looks at it very differently, saying, go and make the drugs and make them cost effective. It's very hard to make cost effective drugs when the trials cost $200 million and 9 out of 10 trials fail. To develop a cancer drug successfully, in the knowledge that 9 out of 10 fail, each one costs about $500 million. And if it's a 90% chance of failing, that means you've got to generate 5 billion quid's worth of money to get a really successful cancer drug. And so we're not going to be able to sell the same price as a Mars bar. And Europe's struggling with that concept. I totally understand the principle that the drugs are too expensive. They are expensive, But the Americans say this is a long-term investment and this is how we cure cancer. Europe says, you know, BMWs and cancer drugs should not be the same price. Which is essentially what they are. They cost 70,000, some of them cost £70,000. That's as much as a BMW. And many people think that that's not value for money. The drug should be £5,000 and the BMW should be 70,000.
Do they value somebody's life less? Nice.
The NICE is a very fair organisation. So the one thing you can certainly say about the American system is not perfect, because 30% of patients don't have health insurance. So they don't get the care. What I can say to you is NICE is about as fair as it gets. Everyone pretty much gets the sack. And they pursue equality almost above anything else. And that's how the NHS works, and I don't think that's a bad thing.
A completely different question. Everybody who is from the team here is passionate and committed to these issues. There are pressures on bringing people now through education and to the level of being able to be professionally involved in this work. Is that a concern with having to pay more for their studies, go into enormous debt? People are having to specialize in things that may not have. Will you have a next generation of you?
So we're very much, there's a lot goes into the actual training, make sure the next generation are coming through from that side. Both there's obviously the whole junior doctor side of things, and they through our clinics get experience of clinical trials and obviously talking to patients about it and the process of it. And then there's specific training routes as well. Within there's called JING, which is so the ECMC is obviously what's the main sponsor for our centre from that side, and they have a junior investigator wing, which thank you, you've on the committee. Yeah. So again, and so there's education sessions from that. They learn how to write trial protocols and put forward their own ideas, get feedback on it as well. And then the European version side of that as well. So it's very much it's the heart of what we need to do when we're looking at future plans, when we're writing our 5-year grant renewals. Very much the key is again, how do we get to the next generation about developing some new areas? For example, we've got a new head and neck consultant who's just come to join us. He's just finished his training and again very passionate again. So we're going to helping him through. Adam from the lung side as well has been a relatively new investigation, but again is coming through from that side. So absolutely is the key to sustainability as well as just bringing new ideas, fresh thinking, and all the rest of it as well. So it's very much at the heart of what.
Wasn't implying that you were old. Just mean that everybody always has to think about what next.
Absolutely.
I'm not sure the UK is, from a global perspective, the UK is very well placed in biomedical research. And the reason why that's the case is we do have good universities. There are many things the UK is not good at, and I'm very happy to highlight those, but we do have good universities. When you look at that annual list, Oxford, Cambridge, UCL, Imperial, they're global top 20 universities, some of them global top 10, 2 of them global top 5. And that's unusual, actually, because if you look at the normal list, the UK doesn't have half the top 10 of anything. I wish it did, but it doesn't in many areas. We also have an organised healthcare system that has 55 million people engaged in it, getting almost identical healthcare. And so if you put those amazing universities with a 60 million person healthcare system together, and you integrated those into biomedical research, we should be by far the number one.
iPhone 4, no.
The United States
The
of
new
America.
one, sorry. I think you'll do well to find one of those.
this because you're doing additional work that's associated with, you know, something might go wrong, this might work, this might not work. A huge amount of paperwork, spectacular amount of paperwork in these clinical files. And so if you were a busy doctor, with lots on your plate, working in Southampton, which is a fabulous hospital with a good university attached to it, why would you put your hand up and say, this is what I want to do? Well, that's essentially how the UK sees this type of research. We see it as a hobby for the vast majority of the work that we do. And that's why we're struggling to compete with Spain, where really we should be as good as America in this field. Is that answering? Is that alarm?
Has anyone online got a question they want to ask?
A question which I'm asked frequently is, and Pete, I'll ask this question to you, is what does breast cancer look like, or what does cancer generally look like in 5 years' time? What are the next big transformations that we're going to see? What's going to be different in our cancer hospitals? And I think from the cancers I do and from a more general perspective, I think we're developing a lot of new systemic therapies. So the amount of patients living with cancer on treatment is going to increase. So that's the first thing, is there going to be a lot more people on cancer treatment, because we haven't managed to cure a lot of cancers with one injection. It doesn't look like that's going to be the answer to this question. It looks like it's going to be more like diabetes than a chest infection. And if that's the case, we're going to have bigger units, bigger systemic therapy areas. We'll probably have to deliver a lot of this therapy at home, because building bigger and bigger hospitals with bigger and bigger infusion units is going to be difficult. That's the first observation. The second is we've been talking about personalised therapy, the right patient, the right patient, the right time, the right treatment for the right patient at the right time, for a decade now. And that hasn't really worked. We haven't perfected that issue. And the vast majority of treatments we're still giving to unselected patients. But for the first time, some of that work with CT analysis, but there's other analysis as well, suggesting we are beginning in solid tumours to enter into a real era of personalised therapy, where you will have a blood test taken, which will determine what treatment you get, rather than getting a bus full of people with bladder cancer and all giving them the identical treatment. And that is going to be a big change for us. So I think those two issues I see being important for the future. What's going to happen in breast cancer next 5 years?
Yeah,
10 years.
next 10, yeah, 10 years. So I think, I mean, you touched on some of the important points, and there's some things we're moving towards already with this. So if you think about, as we were talking about, the duration, particularly in the early breast cancer setting of some of our treatments, if you're HER2 positive, you have about 15 months of treatment with it. And some of those things are actually quite straightforward drugs, which actually just go under the skin, things like Phesgo. And we're already looking at whether we can actually move towards giving those at home, for example, and things. So again, I think one of the big things is going to be a de-escalation in the early breast cancer setting, and that partly will come into the effect with when you're talking about the personalised medicine. So again, will ctDNA work in quite the same way as it seems to be in bladder cancer? Can we use it to target those patients who need more intensive treatment? And that's going to there's work ongoing around that as well. I think losing anthracyclines would be a big step forward for breast cancer. Again, they've underpinned our work for many years. Lots of toxicity. The US are trying to move away from them again, with basis of whether there's firm evidence for that can be debated and that stuff, but I think that could be the case. I think the other thing that we're starting to see, particularly in breast cancer, is a lot more molecular stratification coming into it. So actually, there's more gene targets coming in. So some of you might have come across some of the PIK3CA mutants. So alpelisib is a drug, BRCA, for example, with the PARP inhibitors. These all involve us actually taking usually a blood test, sometimes even a mouth swab now, to send off to the lab to sequence the genes to see if there's any particular changes in that. And so we're going to be doing much more of that, both with targeted, but also that we can now do that what we call whole genome sequence for certain patients, where we actually look throughout the whole genome and actually see if there's anything available any changes that they might have drugs that we can do from that side. And I think one of the challenges then is if we've got this technology which we can do, actually then how do we get the drugs to, if we do it, and there's lots of regulatory and other issues around that, and that again, where we're talking about coming back to working together as a collaborative way, I think will be really important. So I think those would be the things. So kind of de-escalation of treatment, more targeted, particularly through CTD and other markers, but also molecular targets and stratification coming up.
Can I ask one quick one?
Super quick.
Very quick one. It's probably when I come here on a Tuesday and I have my bloods done, when am I likely to see the circulating DNA being looked at in there?
So Frankie's got a project at the moment,
Yeah.
which is an NHS project, not a research project, around testing patients in the next few months. In the United States, they're doing it already in some cancers. And I think there are 2 or 3 trials coming out over the next 4 or 5 years that will hit a tipping point, which means suddenly we're just going to do it. Sometimes in healthcare, transformative moments happen quite quickly. And that body of evidence is building up and the dam is going to burst. So I think this is going to be relatively soon. Because if you're a patient, you say, okay, have a year of therapy with a 10% chance of life-changing toxicity when you clearly don't need it, you're going to say, I want to have that blood test. The therapy costs £70,000. The blood test costs £1,500. So it's cost efficient and it's good for patients. Organisations like the NHS are going to grab it with both hands.
Can I just add to that quickly? I think one technological issue that we need to overcome is how quickly it takes to get the results back. And there's types of, when Tom was giving his talk, he was talking about making personalised ctDNA tests. So they took a bit of the tumour, they found the changes. You can have agnostic ones where you don't need to do that as well. And there'll be pros and cons to both. But for example, in the metastatic setting, again, it would be lovely to have ctDNA monitoring where you could change treatment. But again, not like a blood test, you get it back a few hours later to make a quick decision. If you've got to wait several weeks for it to come back, that's not quite so clinically useful in that setting. In the adjuvant, so in the curative setting, a bit more time to actually get things set up. And that's where we're seeing it being of more use. But I think if we can shorten that time to actually get the results back, then the opportunities for it actually really develop.
Wonderful. We're going to close there. Thank you so much to our